Hope everyone's well. Welcome, good evening. And today we have a really exciting webinar on breaking bad news. Now, just to briefly get started, I was going to do a small introduction, but I'm going to try and skim over that as we are a bit late for time. So I'm just going to jump straight into introducing Dr. Sanam Rahman. She will be talking about breaking bad news. And I think at the end, what we will do is we'll have some clinical scenarios. You guys can feel free to jump in. And basically, we'll also have a Q&A. So feel free during the webinar to just type in any questions in the Q&A box and just have a bit of fun with it, even if it's not completely relevant to the topic. Take your shot anyways, and I'll be just paneling the questions and asking Dr. Sanam them. I'm just going to share my screen. I'll just hand it over to Dr. Sanam Rahman.
Thank you so much, Mohsen, and Dr. Han. So guys, today I'm going to be speaking to you guys about breaking bad news. Well, having graduated from Bulgaria myself, we don't really get to do that much over there, and especially with the language barrier. So it is something that we do not get practice as medical students, and I would highly advise that it is something you guys should practice, because it is a huge part of your job actually, when you do start working as a doctor. But before I go into it, I'd just like to say, so yeah, my name is Sanam, and I graduated from Trakia University last year in 2020. And now I'm working in Leeds Teaching Hospital Trust, so in one of the hospitals in Leeds. And yeah, so far so good. Before I go into it, I'd just like to apologize. Sorry, my camera's not working. So, you know, unfortunately or fortunately, you guys cannot see my face today. But I'll try to make this as engaging as possible. And please, if I ask some questions, there's no such thing as like no silly questions or silly answers. So like just shout whatever out, and it will probably make it a bit more interactive. So yeah, before I start, does anyone know what sort of, in what context, you know, what sort of bad news as doctors we have to convey to our patients, other than, you know, the bad news of telling them that they are sick? In what sort of settings will we have to, you know, give them bad news?
Unfortunately, we don't have a chat box, so you're just going to have to give them the answer as well as.
Okay, well, so that's no problem. So yeah, so as FY1, I'll be completely honest. So, you know, the heavy duty stuff, like, you know, your patients having cancer, or, you know, your patients, you know, going on end of life treatment. If you are on call and there's no one else around, yeah, it is your, you know, it is your responsibility to inform the patient. However, a lot of the times, for example, you're looking after a patient from Monday to Friday, and they've gotten some tests done, and the next day on the ward round, you go and check up, you know, the CT scan that they had yesterday, and you see that, you know, they've had mass somewhere. So in those occasions, you're very, very lucky. You will have, you know, if the consultant's on the ward that day, they will come with you when you're breaking the bad news, or they'll do it. So there's a lot of different settings where junior doctors have to do it. So for example, if you're putting a patient on end of life, it's maybe a decision you do have with the consultant, but sometimes it will be up to you to go in and speak to the patient, or, you know, speak to the family. Especially in COVID times, I've found that I've had to speak to the family a lot, because obviously they cannot come in, so I have to communicate with them on the phone, and it's a very good skill to have. So without any further ado, we'll just get into it. So I don't know if many of you know our bookman, but it's a very, very wise phrase from him. An expert in breaking bad news is not someone who gets it right every time. He or she is merely someone who gets it wrong less often, and who is less frustrated when things do not go smoothly. Now, I can vouch that there has been many situations where I've gone in to, you know, explain something to a family or a patient, and just you know, so much questions are hurled at you where I'll be honest, as a junior doctor, sometimes you do not know the answer to, but the more you do it, the better you get at it, and the more capability you have to handle those situations. And just a little meme there. So the doctor is, I have bad news and worse news. The bad news is you have 24 hours to live. and the worst news. I meant to tell you yesterday, so that is not how you big bad news. So there's different strategies of doing it, and I found myself really kind of sticking to one, spikes, the very first one. But I'll go through a couple of them, and then we'll concentrate on the one I think that helps me the most. And for each conversation is different. You can't really have a structure to, you can't really maneuver a conversation because everyone's different, but it is very, very helpful to have a structure because you know what to do in certain situations, you know how to handle people's emotions. So I really do think sticking to a structure does help. So the first strategy is known as spike, or ABCD, breaks and cons. So spikes in ABCDE appear to be the most commonly used. And I myself use the spikes approach, which I will go through in detail in a second. So the ABCD approach is advanced. So by advanced, you mean, advanced planning, kind of plan where, the conversation is going to take place. Then we have build a therapeutic environment and relationship. So, like I said, in a quiet environment, communicating well, deal with the patient and family's reaction. So having empathy, listening to what they're saying, reacting in a way that, they'll feel comfortable with, and to encourage and validate emotions. I'm not going to expand on these anymore. Like I said, I'll go more into detail of the spikes approach, which I use on a daily basis. So spikes is setting, perception, invitation, knowledge, emotions and empathy, strategy, and summary. So then we'll go into each one of them. So setting. So in a setting, so for example, I'm going to give you a scenario and we're going to carry this scenario the whole way through, going through it. So for example, like I mentioned earlier, I, as a doctor, have been looking after a patient for 1 full week. They're spiking temperatures. We don't know what's going on. They're vomiting. We do all of the investigations, and on the Thursday before I go home, we'll order a CT tap. And on the Friday morning, I go in and I check the results of the CT tap. On the CT tap, we will have, for example, a mass in the sigmoid. So this is now, I can presume it's not cancer, but I've always noticed if there's any masses that don't occur quite normally or regularly, or if there's many masses everywhere, we're more than sure it's, a tumor or a cancer. It's a cancer until it's proven otherwise. So with this information, my first thing is with S from my Sparks mnemonic. S is for setting. So ensure that you're in a comfortable, confidential room where you will not be interrupted. So I will always make sure that some patient may be in a bay. So I'll make sure I'll let the consultant know this is the results. We need to tell them. So I'll make sure there's no nurses around. I'll make sure I leave, if we have a bleep or anything, we make sure we leave them outside. Yeah, the perception. So once we go in to see the patient's lying there. And the worst thing you can do is walk in there and be like, how are you doing? By the way, you have cancer. That is not how you deal with it. You really need to give the patient some time. So you kind of let the patient lead you into the conversation. You kind of let them tell you their story so they can piece the pieces together until you tell them the end of it. So you ask a patient events that have led up to now. Ask them what they already know and expect, because sometimes I think it's one of those things. If you've done a scan from the previous day and you've gone home, you never know, maybe another doctor has seen it who's on call and they've come in and told them or informed them. So you ask them what they already know and expect, and spend some time trying to get them to say what the diagnosis is. So what do they know of their condition already? So for example, I go into this patient and he's there from the day before. And this is an actual patient that I have and an actual case that I've actually gone through myself. So it was my very first time having to break bad news. And this patient had a mass in their sigmoid colon and had many masses in their lungs. So they had metastatic disease. So I go in and go, how are you doing today? I hope, how are you feeling? And this patient proceeded to tell me they're feeling a lot better. They thought they had a temperature the last couple of days, but they were getting better. Maybe whatever treatment and medication we were giving him have been helping him. And he feels like he opened his bowels today, which he wasn't able to for the last couple of days, and he feels like that was the real problem. He feels 10 times better, and the only thing he's asking is, when can I go home? Obviously, as a doctor, this is very, 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 a very difficult situation when you're going in to give them such terrible news and they feel like they're completely medically optimized to go home. So you kind of ask them what's going on. Next slide. So these are some kind of phrases that you can use. So could you tell me what's happening so far? Do you have any idea what the problem might be? Is there anything you have been worried about? So in my situation, I was asking the patient, what's going on so far? Can you tell me what the doctors have told you? How do you feel? Is the pain still there? Because he was complaining of abdomen pain. Is the pain still there? He said it's gotten better. Is there anything that he was worried about today? And his answer straight up was, no, I'm feeling so much better. When am I going home? And before he said anything else, he was like, I just wanna know the result of that CT tab. Hopefully there's nothing on it so I can go home. So invitation. So the next thing is, well, you have to check with the patient. If the patient wants to know the results now, or if they're like a family member or friend to be present. So in my case, I explained to the patient, he gave me all his history, that he's feeling a lot better. And when he asked me what the results of the CT tap was, I stood there and I was like, oh, I then explained, okay, so the reason we did the CT tap was because we couldn't find what was going on, and it gives us imaging of your whole body, just from your chest down to your pelvis, so we can see if there's any abnormal activity going on. And I said the results have come back, but I wonder if you want me to tell you the results right now, or is there anyone else, like a family member, or you want us to call up, or have on the phone. I think this is quite a good way, because it kind of leads them into saying maybe it's something important, because if it wasn't something that important or something out of the blue, we wouldn't really be asking, do you want anyone else to be present? So it's the first step leading into letting them know and kind of prepare their mindset for maybe they're going to be told some type of news that they will not be happy. So some leads off you could do: I do have the results here today, would you like me to explain it to you now? Would you prefer a family member or a friend present? So when I did ask that, the patient was taken aback a little. He was like, no, I think I'm okay. I would like to know the results now. So then from Sparks, we have K for knowledge. So this is given the diagnosis. And I think this is the hardest part of the scenario. Or, I mean, I think it's one of the hardest parts that doctors have to deal with on a daily basis. I remember there was a certain patient that my consultant had to go in and tell him. And even I'm sure she's broken bad news to hundreds of patients. Even then, in her actual position, she was like, oh, I don't want to do this. I don't want to have to do this. And it's going to be a difficult one. So from that, I gather, no matter how experienced you are, no matter how many times you've done this, it's still very hard. So it's completely okay for you to be an F1 starting off and finding this difficult. So for given the diagnosis, so build up the result, giving a warning shot. So like I said, we already have that one warning shot where we say, do you want your family present? Chunk the diagnosis. So now I think when it comes to giving them information, the best thing you can do is just chunk it. And by chunking, I mean like give them a bit of information. So for example, your results have come back, and what was on it is something that none of us were hoping. And then you pause for a bit, like let that settle in. The worst thing you can do is go into a patient and be like, oh, your results are back and it's very bad news. This is the diagnosis, this is the prognosis. Like, I think we need to understand that, if we were in that position, we would want some time to kind of take everything in. So yeah, have a stepped approach to everything you're saying. After every statement you say, please pause and wait for the patient. So what I kind of do is I let the patient guide the conversation or the consultation, because it really is about them. I don't want to be going in there and bombarding them with questions, because I mean, as humans ourselves, when we find out news that we're not too happy about or concerned about something, I'm sure we might have a million questions in our mind, but we probably cannot get them out at that exact time because there's so much things racing through our mind. So make sure you pause and let them ask you questions. Silence is the best at this point. There are a million things going through the patient's head. If the silence is very awkward, you can ask questions about how they're feeling. So for example, you know, I'm so sorry I've given you such shocking news. How do you feel about this? What are your main concerns? Would you like to explain to me what's going through your mind? So if you want to, just dive into it a bit deeper, let them kind of ponder on it and then go ahead and explain things to them. So the next thing is explaining. So the main thing is to do not launch into explaining things. So, I've written during K there, I mean, during knowledge and afterwards, the patient must lead the consult. So you don't want to go, we've gotten the results and, we weren't it's not what we were hoping for. And then you don't want to go straight into, by the way, we think it's this type of carcinoma, with this, there's this treatment available. No, you should never, ever do that. The initial consult, the initial presentation of it should be the patient finding out and giving them time. Just it's a bit of empathy, and only answer the questions they ask you. So it kind of shows empathy. It kind of shows that you're listening. It shows that you care and that you're really sitting there for them, giving them the time that they need. And again, chunk and check, and you requested explanations. So the way like I said, once you go into the knowledge, as you know, we took a biopsy, and unfortunately the results were not what we hoped for. I'm afraid, unfortunately, I'm sorry to tell you that it is a tumor. And if you guys have noticed, I have paused in between because, again, so much is raced into a person's head. You just want to give them that time. And so in my situation, when I did went into this patient and explained it to them like that, I did the same thing. I just think the most important thing in this case is the positioning of your body. I've seen it being done, and I think get to eye level with the patient. So if the patient's laying in their bed, sit down on the ground, hold their hand, really just show them that you're there for them, and that, this is probably the worst news they've heard, but you're there to support them. And E stands for emotions and empathy. So acknowledge and reflect their emotions back to them. So like I said, body language, like if they're crying, just, give them some time, sit down, hold their hand, get them, a glass of water, have some tissues with you. Just, I think in that time, people just need some support. And don't try to solve their problems or reassure them. I'm sure in situations as humans, we're inclined to be like, everything will be okay. Don't worry about it. None of that should have ever be said. Just, give them the diagnosis, sit there and just sit there with them. Silence is the best key here. I think instead of you talking, the patient does really tell you how they feel. So from here, I can see the news was a huge shock. Pause and wait. You appear very anxious. Pause and wait. So you've told me that your biggest worries is telling your children and losing your hair. In that situation, try and offer them stuff. Do you want us to contact your family? Do you want us to tell your family? Is there anything we can do in this situation? Is there anything I can bring you? Just offer them as much as you can. You're very quiet. Can I ask what's going through your mind? How are you feeling about hearing the news? What's upsetting you right now? And our last thing is strategy and summary. So once you've told the patient and you've heard them out, I'm sure a lot of patients, the main question I get. So for example, I explained that this patient has a mass seen on the CT tap, and their first reaction was complete shock. And that's when I sat down on the ground and I held his hand, and he understandably burst into tears. And his first question was, how am I going to tell my wife? And I sat there saying, I can call her in if you want. If you don't want to do it yourself, I can call her. I can do it over the phone. Whatever you need right now, you can tell us. And he told us that he would like to do it himself. And then maybe after a little while, once he's told her, she can come in and we can explain everything to her. And we give patients that option, especially, I know it's quite hard in COVID, but we still have that much of, I think when we're breaking such terrible news, we do want another family member present if the patient wants that. Summarize their concerns, if they're worried about their children, if they're worried about losing hair, you can explain to them, we can help them with that. We could tell their family, or there's support groups for stuff. But again, in the initial meeting or the initial time you're telling them something, it really is minimal explanations. And again, before you leave the room, ask them how they're feeling. I vividly remember an encounter where my consultant was telling someone that they're being placed on palliative care. And after everything was done, before she left the room, she was like, "Oh, I wish I could get you some vodka, but I don't think I'll be allowed. So you can ask for anything but alcohol." And it kind of just adds that lightness to the air and shows them that, we are there to support them and we are there to help them get through this tough time. Breaking bad news is frequently a tense and disturbing experience for both patient and the physician. Your patient emotional response will be difficult to withstand unless you have a strategy, which, sorry, with which to address them. Not more than 50% of communication of bad news is nonverbal, focus on the patient's concern. So the majority of, what you show the patient is not from what you say, is how you show them, by body language, by, showing them that you really, really do care about them and you are there to help them in this time. Know the facts. So, make sure you know the patient details, because in this situation, someone can ask you so many questions. And the worst thing is where you don't know your patient well enough. So if they're asking you and you're standing there. However, I will also say in this situation, don't be afraid to tell the patient that you are not an expert in this. So I've had many a times where, a patient will ask me so many questions like, "Oh, is this curable? Is this?" And I will say straight up, I wish I could tell you everything and the prognosis backhand, because this is not my specialty. I'm not an expert in this. So we will have to sit down with, the experts. We will have to sit down with the specialists, and they will have a conversation about, see what we can do further. They'd want to remove it. There's radiotherapy, chemotherapy. There's so many options, but I cannot give you a solid answer right now. Acknowledge the limitations of a physician and medical science in general. Finally, practice communicating clearly, completely, and compassionately. Um, a really good tip that my dad once told me as well. Whenever you're sitting with a patient, regardless of breaking bad news, or if you're treating a patient, always think, imagine this was my mother and my father in this position. And how would I want them to go through a situation like that? How would I want the doctor who's there giving my own father or my own mother this bad news? How would I want the doctor to react? And how much compassion would I want them to have? Just another meme. You'll soon be at peace. The man, am I dying? No, your wife is. And yeah, so that's the presentation. I hope I didn't go through it too quickly. I think it's just one of those things that if you practice again and again, and you kind of see it once or twice happening, it becomes second nature to you. But it's just one of those things that I do highly, highly recommend practicing. And even as a junior doctor, like, for example, it may not be, telling a patient that they have cancer, or telling a patient we can't do anything. It might maybe just calling up the family and giving them, an explanation of the disease that we've, found so far. And any conversation you have with a patient, or you have with a patient's family, should really follow those rules. Just, because as doctors, we sometimes forget not everyone can understand the medical terms, or, we get caught up in a web of just using abbreviations. But we really need to realize that, you know, we have to really put it in, simple language for people to really understand what's going on. Any questions so far?
We are not supposed to try to solve their problems or reassure them, then how are we going to gain their confidence for further treatment? Oh, that's a good one.
So, I mean, yeah, it's a very good question. But, in that moment, they will ask you a lot of questions and you have to, answer them as much as you can. But it's not about problem solving in that moment. It's about showing them that, we can help you. So if they ask us anything like, is this curable? You'll be like, yes, maybe it is, but I cannot say for sure until we get a biopsy. So you're not trying to solve their problems. The main thing I meant by that point was, sitting down there and telling the patient everything's going to be okay. I'm sure it's nothing. Those type of slurs. You don't want to say anything without knowing what it is, if that makes any sense.
Absolutely.
Yeah. And I think in gaining a patient's confidence, or their confidence in you, it takes more than solving their problem. I mean, there's so many patients I've come across who, I haven't given them treatment, but just sitting down and having a conversation with them and getting to know them, I think in normal human day-to-day interactions, you're more likely to trust someone that you have a connection with rather than trusting someone who's giving you facts.
Absolutely. I think another question is, somebody asked, is this session for doctors only, or can mental health students join? I think honestly, anyone can join you.
I really think anyone in the health sector can benefit from this, because it's just, again, it's something that you come across so often.
Mm-hmm. I think that's something I think you just have to do generally as a human being at some point in life. Is in fact, we all the time deliver bad news. Like, anytime I've not passed an exam,
with your parents, with anyone, it's a part of life. It really is. And I really do think having that skill helps you so much in the medical field. I'm sure you guys are going to have a webinar and it's sometime soon, but we have something called a respect form, and it entails the do not attempt resuscitation conversation. And I feel like that is a part of bad news as well, because you're going to a patient and telling them, as doctors, we pre-decide these things. Like, we look at the patient's condition and their frailty and, can they withstand CPR? And we pre-decide that. And then we go and tell the patient, like, this is why we have decided that. But as a patient sitting there, someone who's not that educated in, the medical sciences, for them, it feels like you're going in and telling them, oh, you're very sick right now, we're not going to give you CPR. So having these skills and having that, knowing exactly what to say, explaining to a patient, you are not imminently dying, but if, in a case, if your lungs or your heart were ever to stop working, for us to come and perform CPR would be futile, because, first of all, it causes so much damage to the body. Second of all, then after, if you even make it through, there's a certain percentage, let's say 1 to 2%, that make it back with CPR. You have to go on a ventilation and stuff. And it's very important for us as doctors to know how to explain these things so the patient understands, rather than feeling forced into a decision or, being told we're not giving you CPR, if that makes sense.
Absolutely. I think that's the other thing. Like, I think there were 2 massive lawsuits over this, which caused, I think we did a webinar on this last month, actually. We were talking about ethics, and it was 2 huge lawsuits filed against just the NHS as a whole and the healthcare system. And it wasn't because of incompetency or because they weren't doing their job right, or even because they didn't make a decision. It was really just because they just didn't include the patients in the decision process. There wasn't any...
And I literally recently on Friday had a patient who, I went into her, so she already had do not attempt resuscitation form, but then it was revoked because she felt like, she was forced into the decision. And I had to go into her on Friday again and be like, look, we need to kind of fill in your respect form, because it's something I do for every single patient. I'm not coming in here and being like, telling you. But sitting down with that patient and listening to her, I get it from her point of view so much, because if I was in that position and like, someone were to come in to me and be like, this is what we're doing, we're not going to give you CPR. And if it's not explained properly as a patient, you'd be like, why do I not deserve a chance of life? So it's one of those things, just to learn to explain things so they go, okay, that makes sense and I agree, rather than feeling like we're not really gonna treat them when they're sick, when they need it.
Yeah, absolutely. I think another interesting question asked over here by somebody is, so when are you really expected to start breaking bad news as a junior doctor? So for
So
example, are you
like
going
I
to
mentioned, the heavy duty stuff, like, you know, someone having a mass or someone having some sort of diagnosis, the consultant will always come in with you and do it. And I'm very thankful for that, because I've learned a lot from it. But it's not, it doesn't go to show, for example, if you are on call and someone's, you know, had chest CT comes back and there's a mass on it, you can go and explain to that patient, you know, oh, we found something, you know, this is what it is, we'll know more tomorrow. But even in those situations, you go in and explain stuff to patients. So you still need to know how to deal with these situations, because they will ask you questions.
Absolutely. I think actually a question, because I was asking a couple of students earlier if they had any questions for now. And I think one thing a lot of people were wondering about was, obviously when you give somebody bad news like that, the first thing they're usually going through is denial.
Yeah.
And how do you deal with that in terms of when somebody's just completely not accepting what you're telling them in that moment? Because, you know, like,
Um,
tell somebody you have
yeah, no,
cancer.
I completely understand as well. And I just, it's one of those things, like, you know, with denial and happiness and, you know, anger in these situations, you just need to let it all sink in, and you just need to let the patients, you know, kind of, if someone's sitting there in front of you and denying, like, no, I cannot have this, and be like, I'm so sorry to give you this news. And yeah, maybe, you know, what we're saying, maybe it might not be cancer, but we will have to do further investigations to find out what it is. And I think if you take everything step by step by step, you don't, you know, bombard them being saying, oh, I definitely think it's cancer and we have to do a biopsy. You know, you'd be like, look, we are not too sure what it is, but we have to expect cancer just to rule things out. And then I think as time goes on, you know, if they get a biopsy and they're still in denial, it's just another thing to kind of explain to them, you know, this is exactly what is happening, and it's reality.
Absolutely. I was thinking we can maybe have a go at doing some scenarios with some of the participants if they're up for it.
Yeah,
Um,
and I think if someone, I can, me and you can do a scenario and then kind of present it how it should be. And then if someone from the audience wants to be a doctor and I could be a patient.
okay. Yeah, let's go for it.
Yeah. Okay. But before we start, does anyone have any questions? I don't really know. Sometimes people tell me I speak really quickly and explain things really safe. If anyone has any more questions on what I said.
I think the ones asked are pretty much addressed, so
Okay.
we'll just give them a chance while we're doing our scenario to ask any more if they have it.
I'd also like to say, one thing I found quite helpful when I started F1, because I'll be completely honest and candid about this as well. In this situation, initially, I felt like I was drowning. Like, I felt like, oh my God, how am I ever going to get used to this? And my very first patient that I did have to break bad news to, like, I really had to be like, son, hold it back, don't cry, no cry, because you do build that relationship with the patient. So one thing that I really, really did find that helped me was YouTube videos. Just watching, just what, you know, you can observe so much just watching loads of stuff on people breaking bad news to their patients. And there's so many role plays out there. And honestly, in the moment, like when you are hit with a hard question, then you just know how to deal with the situation. Because one thing I can guarantee in medicine and being in F1, you will be thrown into a situation blindsided where you just have to be like, okay, this is my problem and I have to deal with it right now.
Yeah, no, absolutely, absolutely. I think that's one of the other things. I think there's a lot of lessons to be taken away from a lot of the people you talk to, because to my surprise, some of the experience I had when I was doing placements was a lot of them took it so gracefully, and I
Yeah,
appreciated it. I was just like, if I'm old and somebody told me that, I
yeah.
would not be happy about it. But they were just,
No
they've just,
way, no. And it's surprising how people just come to terms with stuff. Like, I mean, there's also the aspect of it where you are, giving palliative talk. So, for example, we have a patient and, there's not much more we can do. They're very old, they're very frail. Any more antibiotics, nothing will, make the outcome different. So, going into them and being like, we're thinking of putting you on palliative pathway and stuff, and even explaining that. And as a human, like, put yourself in that position, being told that there's nothing else we can do. So
Yeah,
it's just, I always say as well, and I think in medicine, we have the patient, that's the computer patient, and then we have the actual patient. And I think
yeah,
we're in a time of medicine where, the first thing you do in the morning is you go and you check the notes and you check the labs and you check everything on the computer and you've decided a plan. And this is all done without seeing the patient, who's the main problem is about. So I think we've gotten to, a lot of doctors are so efficient with it, but like, I think we've gotten to an era where, the patient really is in the computer sometimes. And then when you go, so I feel like, we really need to train doctors on, when you go to the patient, have that sympathy, have that empathy, have that, human interaction where, you tell them that, we are here to help you.
yeah. No, absolutely, absolutely. I think before we just jump into this, what I'm going to do is I'm just going to send the feedback form, the link for it. So I know we don't have a chat over here, but basically, if you just click on the Q&A, you should be able to see the answers, and it should be in one of the answers. So please, please, please do fill that in, because we are crazy about feedback over here, and that
Yeah, we are.
and you get your free certificate for attendance as well by filling it in, as well as 50% lectorio discount code. Should we get started?
Yeah, okay.
I'm way
So
too happy for this right now. I'm way too
please
hyped.
don't hurl anything ridiculous at me. Okay. So I think before this scenario starts, I'll just give a brief kind of outline of the patient. I think this patient, let's say you have a pancreatic mass and you've previously had some stomach pain, and you've had an ultrasound, and after the ultrasound, we saw that there was something there, and then we did a CT scan and we've got the results of the CT, and there's a mass on the pancreas head. Okay.
Okay, so I'll start with a knock. So,
Yeah. Come in.
hey doc.
Hello, hi Mohsin, how are you doing? Please take a seat. My name is Sanam. I'm one of the doctors.
Nice.
I'm going to be I'm going to be looking after you today. So sit down.
Great.
So how are you doing today?
Yeah, not bad. Just sort of cracking on, getting on with it. Busy day.
All
Just got.
right.
Yeah, I was running late, but thankfully so were you, so it all worked out well.
That's no problem. We all always run late. So Mohsin, so far, I've just called you in to ask you, a couple of questions, and do you know what's going on so far? What has been explained to you? You came in last week, you had a scan. Did anyone explain to you why we did that scan or what symptoms you were having?
Well, I think just over the last couple of weeks or months, I've just been having pain just in my tummy area, and came to the doctor. They obviously took me in for ultrasound, and that little thing that pregnant ladies use.
Yeah.
I didn't know they use it on men. And yeah, I think basically, I think that they were thinking the issues might be gallstones, they said.
Okay.
And then they called me, I think, a couple of days after that as well for another scan. But I think really that was as far as it went, to be
Okay.
honest.
And are you currently having any symptoms or any pain or?
Yeah, just the same sort of pain, really. So just sort of sitting there, really, just really in my stomach belly area. So that's not really gone away. Yeah.
All right, okay. And you know when you had your very first scan, did anyone explain to you what was on the scan or why we had to do a second scan?
Not really. I think they were when they took the scan. I think I tried asking them about it. I think they were still trying to go through all the details and everything, and then they called me back for a second scan. I don't really ask questions, to be honest. I just
Mhm.
got on with it, really. So,
Okay,
yeah.
okay. Well, the reason we did the first scan was just to find out why the pain was there initially. And when we did the first scan, so the first scan is called an ultrasound. And when we do an ultrasound, it's a good scan. It can tell you what's going on, but sometimes it's not the best scans. So when we did the scan, we saw that there was something there. We saw that there was, maybe something that we need to investigate into further.
Milestones, I'm guessing.
Yeah. So when we did the second scan, um, unfortunately, there was something there that none of us hoped, but we found a mass on your pancreas, the head of the pancreas.
Okay, so gallstone, right?
No, so I'll explain. So the pancreas is an organ in your abdomen at the top. So I'm showing you where it is now.
Mhm.
So it's an organ quite at the back of your abdomen, and it controls the hormones release, so the fluids release, and it dictates how your food and everything is digested. So that it's a completely different organ to where your gallbladder is. And there we found a little mass, unfortunately, where the head of it is. And I'm sorry to tell you this, unfortunately, it possibly could be a tumor. I'm so sorry to give you such shocking news right now. I know it's a terrible bombshell to place on you. Or is there any family you want us to call, or is there anyone you want us to
Like,
call and explain this further, or would you want me to
you
go
guys
ahead
can
and
cut it out, though, right? Like, you guys do that with tumors all the time.
sorry?
You guys can like cut it out, right?
Yeah,
Something.
so in these situations, there's surgery, there's radiation therapy, there's chemo. I cannot for sure tell you what we can do with it, as we need to sit down with the specialists. So the specialists who look into this further. I can't say for sure 100% it is a tumor right now, but we have to lead down that line so we can rule it out.
Okay.
I'm very sorry, I cannot tell you if we can excise it right now. Going off the way cancers like that work, we'll have to speak to the surgeons, and we have to speak to the oncologist specialist to see what further planning is.
Okay. But is it definitely a tumor? Can you do another scan or something? Like,
Yes, and this is what I want to clarify as well. I don't want to tell you right now 100% that you have a tumor, but we can do biopsies, and we can do other scans, and we can revise what we really do think it is.
but I'm guessing with the second scan I had, because it was a lot more accurate, that's probably conclusive enough.
Again, I wish I could tell you conclusively, like, yes, this is it, but we really do need to sit down with everyone else and see what it is.
Don't really know what to say, to be honest. Um, like, how bad is this?
Well, with if it we are thinking of pancreatic cancer, it has different type of progressions, and it really depends on how long it's been there for, how long has this been going on. But again, I cannot give you a definitive answer right now. I can understand your frustration. I can understand what you're going through right now, and if there's anything we can do to help, anyone we can ring. Is there any family that you want us to contact?
Um, no, she's at work. No, not at the moment. I think I'd probably best go home and talk to them myself.
Okay. I can suggest something. We will sit down with the specialists today, and we can sit down with all the consultants and we can discuss this over. And if it's more helpful for you, you and your wife can come in tomorrow and we can have a more detailed discussion about this, if that's what you'd like.
Yeah, I think I'll just come in tomorrow myself. That's okay.
Okay, it's entirely up to you. Whatever you prefer, we're here to help.
Okay.
Okay.
I mean, don't really know what to say, to be honest.
That's very understandable. I'm so sorry you have to sit through this and go through this right now. In the instance that if it is a tumor, I've taken the liberty to print out some leaflets and some information about pancreatic tumors, just so you can get more information in your own time. I know we were bombarding you with a lot of information right now, and it's probably all going through your mind. So we would like to give you that space, but also give you that information in your own time when you are ready.
Okay. So is this something I take home and read, or tomorrow?
Yeah, if you want, you can take home and read it. If you want to take some time and think about it, I'll come back and explain it to you today. It's entirely up to you.
I mean, I think, is there someone I need to inform about this? Should I wait until we have more discussions about it? Like, obviously, I have a job and other things as well. Like, is there someone I need to?
So you are welcome to tell anyone you want. You're welcome to tell your family. And once you have more information and more clarity from our MDT meeting tomorrow, which is when all of us sit down and discuss everything with all the different teams, and when you have a clearer picture, then you can explain everything to whoever you wish. Is there anything I can do for you right now?
No, I should be fine. Yeah, no, I'm okay.
Thank you so much, Mosin, for coming in. I'm here the whole day. I'm a call away. So if you need anything, please do inform the nurses to just get me, and I'll explain everything.
Thank you so much, doctor.
Okay. Thank you.
Okay. Thank you. Take care.
And there we are.
I honestly feel like I have pancreatic acid. Feels so real.
Yeah, no, even like it's just one of those. It really, every experience you have won't. It is very upsetting for a junior doctor especially. So it's just one of those things that you kind of just have to deal with. And it puts a lot of pressure on doctors as well. I really do think it affects us mentally as well. Like it takes a toll on you.
Yeah, no, absolutely. I think it's you know what it is. I think you're thinking about it as much as the patient is.
Yeah.
So they go home with it, but just as well, the doctor delivering the news goes home with it. They lose sleep over it as well. They're thinking about it like, oh my God, that poor guy, or oh, I had to go through that today. I just don't think I don't think there's no one who walks away from it happy, but that's breaking bad news is all about. Like there's no, you're just trying to minimize the damage. There's no happy ending over here.
Yeah, and I think it's also important to, for example, someone with extensive metastasis. I had a patient who's like 6 nodules in the lungs, 2 in the abdomen, 1 between like the kidney. And it's one of those things that they asked as well. They were kind of like, so what, can we not take them all out? And you have to be honest in those situations as well. Use your best clinical judgment. Be like, usually we can, but seeing the extent of it, I don't think it's surgical. You're able to surgically remove it. However, there is different options like chemo and radiation.
Yeah, I think it's a bit of a tricky one because you were obligated to tell the patient.
Yeah.
But obviously you need to do that as soon as you have even close to conclusive evidence of but like essentially me as a patient's thinking like, oh well, like you should have talked to the specialist first, and so on and so forth. But like in this situation, I think we were kind of being it was a bit of wishful thinking in the sense where oh, I want to sit down with a specialist tomorrow. I don't think things like normally happen that quickly in a lot of places.
Yeah. Well, you know what, to be honest, in our hospital, sometimes I work in the rest department right now, and we have something called the lung MDT, or like the lung nodule MDT. And it happens I think every 2-3 days. So sometimes you can really discuss it with all the consultants the next day. So from my experience, it does move that quickly, but I completely understand as well, some patients do have to wait a little while longer. Or in some situations we might not have a conclusive result, but then we do get the consultant to come in and explain things to them a bit more, and sit down with them and be like, these are all the different type of outcomes and stuff.
I think it's just obviously a buffer period, because obviously you're still left with that little bit of hope where you're thinking, tomorrow she can talk to the consultant specialist, and they'd be like, oh, what are you talking about? It's a gallstone. And that's why I think a lot of the times they try to be realistic with themselves, but we're just bound by just sort of procedure where we can't say it's more or less pancreatic cancer. Like,
exactly.
I can't say.
And the thing is, as a junior doctor, you know exactly what the steps are before you go in there. So the majority of the times you would have discussed this with a senior, or you would have a senior with you going in doing this.
Yeah, I think somebody asked, how often do you break bad news such as terminal cancer?
Well, the majority what I've come across is when we do find nodules around the place. That's most of the bad news that I've had to kind of go and speak to people about, or for example, telling someone that we're putting them on a palliative care pathway. So for example, I had an old lady, I think she was 90 years old, and she had what was it? I think she had really extensive pneumonia, and she had some atypicals in there. And there was a query of, TB as well. We could have put her on a cocktail of antibiotics, and it wouldn't have changed the outcome. So going in there and expressing this to her completely, sitting down and be like, these are our options. We can do this for you. But, from a medical and a professional educational point of view, the best thing to do here is to go home and enjoy this time with your family, and we'll give you the care that you need. We have packages of care, people come home and look after you, and for you to be more comfortable, we think this is the best possible route. And you really do tell them we're doing everything in your best interest.
Yeah, and I think that's the idea behind the respect form, really. Trying to understand what the patient wants, as well as including and combining that with sound clinical judgment. And I think a lot of people get that because it's always one or the other, but it's a beautiful combination of both. And okay, you want them to obviously have autonomy over their health, but at the same time, realistic medicine's a real thing. So you want them to at the same time be okay, is it, sometimes they always try and fight for it. So they're like, oh, no, can we look into a transplant? You do.
I've really found with a lot of patients as well, initially that's the first very reaction, no, we do want CPR. But then when you explain things clearly to them, I think the one thing that I've learned off by heart is really explaining to patients what CPR is and what the outcomes of CPR are. My favorite thing to say is, we will do everything in our power to stop your heart from stopping and stop your lungs from stopping. So there's other options, we will give you antibiotics, we'll give you drips, we'll give you NIVs, the second level of care. But when it comes to the third ceiling of care, ICU, we don't think that would be beneficial in those situations. So even if we were to, give you CPR, and even if you were to go on ventilation, once we remove the ventilation, you will end up passing away from that as well. So to save you from those situations, and really, really drilling it into the patient, you're not imminently dying, there's nothing wrong with you right now, but if so, we were in a situation where you couldn't express your wishes, we wouldn't want to do anything that you didn't want, and we wouldn't want to compromise your dignity in that situation.
Because what was the formula? I remember seeing it on the respect form. Even it was the scale between quality of life and I think determination to live.
Symptomatic. I think it's a scale between concentrating in life conservation and symptomatic treatment. So like comfortability. Do you want us to, try harder to make you comfortable, or do you want us to try harder to, make sure that, your organs start up again and
Absolutely. Does anyone want to have a go? I think you can put your hands up in the panel for the participants. So I'm gonna wait until somebody does that. I might pick somebody out at random if I'm feeling mean. Oh, okay. Noama's really good. So
yeah, it is.
yeah, you'll have good fun with it. Noama, can you unmute yourself? I'm trying to find you. Allow to
Mohsin, I have a suggestion. You're really good at your acting roles and being a good patient. So maybe you can act as the patient and I can kind of guide Noama alongside you then.
Sure.
Okay. Hi.
Hello, Noama. How are you doing?
I'm good, thank you. How are you?
Not too bad.
Your presentation was amazing, by the way.
Thank you.
Okay. So is Mohsin being the patient?
Yeah. So if you would like to just give him a quick, scenario or whatever type of patient you want him to be.
Do you want to give him a scenario? I can't think of a scenario.
Okay, let me think. Do you want to do another one quite similar to the one we did, or do you want to do like
I have a really good one. So I'm a patient who came in for a blood test because I have diabetes in my family history, and the doctors informed me that I've been diagnosed with diabetes, and obviously trying to offer me medication. And Sanam knows I've been through this. So, and I'm just refusing to believe that I have diabetes. So I think the only background you really need is, let's say I'm just an older gentleman, and my father had diabetes. I think I did this over a phone call. So probably ideal situation to deal with.
Okay. So am I understanding correctly, you've been told previously that there's a risk of diabetes in your family and your father has diabetes, and I'm the one who's going to be telling you you have diabetes. Is that correct?
Well, you're going to be calling me trying to sort of convince me that I do have diabetes, and then obviously try and explain to me at the same time, why I'm taking medications in my best care. I think this is more of a communication skill exercise, but at the same time, you are breaking quite a bit of bad news to me because I'm in extreme denial right now.
Right. Okay.
Let's start with the ring.
Okay, so we're starting with a ring. This is going to be a phone call. Okay, so ring.
Hello?
Hello, am I speaking to Mr. Mohsin Salim?
Yes, you are.
Yes. Hi, this is Dr. Alana. I'm calling from the hospital in Ireland. I think you right. Okay. The hospital in Ireland, your local hospital. Are you free to talk right now?
Yeah, 5 minutes. What is this regarding?
It is regarding your current health situation. I believe you've had a few previous conversations about diabetes. Is that correct?
Game. What is the situation here? Like, what's actually happening? Like, I'm so confused right now.
I understand you're confused, so I'm hoping to offer you a bit more insight on how you're feeling. So what exactly do you know? What have the doctors previously told you about the situation with diabetes and your genetics and your family? What is your
I went
current
for a blood
understanding?
test. They took my blood. They called me like a week later saying I have diabetes. Like, how do you expect me to even, like, begin to believe that? Like, oh, you just took my blood and now I have diabetes.
Right. Okay. So they took your blood. Do you know what diabetes is, Mr. Mossin?
Yeah,
Mr.
yeah, yeah. I
Salim?
know. My dad had diabetes. I know what diabetes is. Yeah.
Okay. So diabetes is, I'm just going to, obviously you have been told this before, but I'm just going to say it again just for you so we both are on the same page. It just means when you're taking in food, which has sugar in it, your body's not able to absorb the sugar that you're taking in from your food. So that results in like a really high blood sugar. So the same test that they took a blood test from you. And the reason that they came up with the result that you have diabetes is because your blood sugar came up very high. And we want to help you because we want
Like,
to.
this is just ridiculous, right? Like, I'm
Mhm.
a healthy guy. I go to the
Right,
gym.
right,
Um, and like, I'm normally on top of my health.
yes.
But like, yeah, like, how do I just get diabetes like that? Like,
So diabetes, as you said it yourself, your father does have diabetes, and diabetes has a genetic
yeah,
composition
but
to it
he
too.
had an accident, and then he got diabetes because of the accident.
He had an accident, and then he got diabetes after that. I Maybe that's when they told him he had diabetes, but perhaps
No,
beforehand you didn't know.
you know what
Sorry.
happened with my father? He had an accident, and then he had diabetes after the accident.
Okay. So does your dad take any medication for his diabetes?
I can't remember. He's not around anymore. And
I'm sorry to
no,
hear that.
I don't think he did. I'm not too sure.
So, well, I'm talking to you about your situation right now. And what we want to do is we've seen the sugar levels in your blood. And I'm just calling you today to try and
You,
organize a plan for you. We know you're a healthy guy. It's good that you're going to the gym. We want you to be at your optimum health and we want to help you get to the optimum health. So that means we need to treat the blood sugar in your blood sugar levels because you said it yourself, you're trying to be a healthy guy, you go to the gym, you exercise. So we need your blood sugars to not be high because very high blood sugar can have an impact on your body,
like,
can
I
have an
think
impact on your brain.
like I just don't trust that you guys can figure that out from one blood test. Like, you guys haven't even told me what kind of diabetes it is. So
Okay.
I just feel
So
like obviously you guys
this
are as
is
informed as you are.
So this is a phone call. This is a phone call. This is me talking to you about the results, and we can organize a time when you can come in and we can have a more in-depth discussion about the results. We can do some more tests and run another test and confirm the results, and we can talk to you about the type you have and then discuss a plan of action because Mr. Salim, what our goal is to try and get you living the best life you can live with the best optimum health that you can live with. And we want to help you do that using medication that will help your blood sugar stay at a healthy level. That's all we want to do. We want to help you have an action plan in place. So I'm calling you because I think you need to come in to have a meeting with one of our consultants, one of our diabetic team, one of our diabetic consultant teams, and we can talk more about what to do in the future with regards to treatment. We can get you on some medication so you can carry on being healthy, going to the gym, carry on your daily life, but you are sure that your blood sugar and everything in your body is working as well as it can be. Does that sound okay? Would you be interested in coming in just to have more of a conversation about it? We can have run another test and we can talk explicitly about which type of diabetes you have and talk about the treatment plans. Would you be interested in that?
Sure.
Yes? Okay, thank you very much for your time, Mr. Salim. I will be sending a letter out with a appointment time and we will organize hopefully getting you some treatment for your diabetes. Thank you for your
Yeah,
time.
that's fine. Thank you.
Thank you.
Bye.
Bye.
Wow, well done, Noama. That was very, very good.
That was
How
actually like half the conversation. he went on to say like, oh, like this was the biggest nightmare of my life.
Oh,
So you handled it really well, though. I think just, patients sometimes do hurl so much at you, but you handled it really well.
I have, so he made a very good statement. There's no, when we go to the point where we are giving bad news, sometimes we don't have the details, the same way you didn't have the details about whether it was definitely cancer, and I didn't have the details about whether it was type 1 or type 2, and I was thinking type 1 because of the genetic composition. And then he mentioned about the car accident, and that kind of threw me off, because I'm thinking perhaps he did have diabetes and it was just undiagnosed until the car accident. That's the only thing that came to my head. I don't know if that was what you were mentioning, Mohsin, but that was what came to my head.
Honestly, like his dad had like diabetes for a long time. I don't know what the situation in that thing was. Like maybe he just found, for some reason, he just thought his dad had diabetes because of a car accident. And I'm like, I just couldn't put my head around it. I'm just like, I understand, but because we were trying to explain to him it's genetic, because
Yeah, that's what I was saying. There's a genetic composition, but it's hard to do on a phone call, definitely, because
Yeah, I think as of recent as well, a lot of our patient discussions are based on the phone, especially with family. I have my whole day consists of speaking to, because a lot of family cannot come in right now because of COVID. So we do have to regular calls to the family and just, update them from a medical perspective.
Yeah. I think that was the other thing really, was that it wasn't even something like we could offer to the person, and like the doctor I was working under was just like, no, he doesn't need another blood test, stop wasting resources. So I was just like, oh god, it was just such a sticky situation. But I think at the end of it, the main message I took away personally was try your best to understand the exact concerns of the person. So I think, like, even for example, the first scenario that I did with Dr. Rahman, I was talking as a patient a lot. I kept mentioning my wife, I kept mentioning my work, I kept mentioning so on and so forth. And I think, like, as that patient, my biggest concern was how this is going to affect my day-to-day life. Whereas as the diabetic patient, I think my biggest concern was I just don't know how all of a sudden I magically have diabetes. And like, I just didn't understand the sort of etiology of it. And I like, I think that's something that could really, really go on to like, but like, how does, you're not going to sit there and start expecting, start explaining genetics to a patient, but like, you really have to layman term it and try and understand what it is they're actually wanting to hear. And then you have to ask yourself the question first, is that something I can even say? Or equivocate or whatever. So yeah, it's just sticky overall. It's just really sticky overall. Does anyone else want to have a go? Come on, somebody put your hand up. Just looking through the names here. Inaya?
If anyone has any other questions related to it, or even in general any questions related to just working or anything.
I think somebody asked I think Sanam, actually you have access to the Q&A.
Oh, do I? Sorry. I just got disconnected, so everything disappeared.
Okay, so basically somebody asked a question. I'll just read it out word for word. This was a useful webinar. Thank you so much. I have a question that is not to do with breaking bad news, though if that is okay. You said you are an FY1 doctor. There seems to be many different names for a FY1 doctor. So please, could you tell me the difference between locally employed doctor, LAS doctor, trust grade doctor, a trust house officer?
So yeah, it is a bit confusing, and I still to this day get very confused as what to label myself as. So I'm myself, I'm a trust grade doctor, but I'm in the FY1 pathway. So the best thing to do is I label myself as a junior doctor, as anyone who's below any specialty training, that's what they are, a junior doctor. The difference between an FY1 and a trust grade 1, an FY1 doctor is someone who's in the FY1 and FY2 pathway. So the majority of the people who graduate from England will be on that pathway. I'm employed as a trust grade doctor, but I'm still within the FY1 and FY2 pathway. So we're doing the exact same. I have the same portfolio and everything. And there's also different names for FY1. So from Ireland, where I'm from, we have senior house officer, which is SHO, and then house job, which is your FY1 and intern year, and then SHO is FY2. So I think there is a lot of different names for it, but like the main term that we are kind of grouped in is junior doctors.
That's an excellent answer. Thank you so much.
I think one thing we say as well, whenever I'm interdepartmental phone calls and stuff, I'll always pick up as in, "Hi, my name is Sanam. I'm one of the junior doctors." So they kind of know what grade you're at, and sometimes they'll be like, "Oh, are you a registrar?" You have to be like, "No, I'm below them." So excuse some of the gaps in my knowledge.
Yeah, I think that's just the word junior. Honestly, it's like they could have thought of something better, I feel, because as soon as you it's like straight away, you're just in question already.
Yeah, but I think even just having that kind of title, as in like I'll always am an FY1, explaining it because I am in my very foundation year of training, so I am an FY1 doctor.
Yeah, absolutely. I think somebody asked a really interesting question over here. So since it's emotionally draining to break bad news, any tips to help doctors sleep at night?
Again, being completely candid, so my first couple of weeks of working in the NHS, I would come home and I would have continuous nightmares about my patients and the treatments and stuff. But I think the further on you get, you just learn to cope with stuff. So like now I just know, like, there'll be days I'll come home and I'll take work home with me. I will 100%. I'll think about a patient, or I'll be like, oh, what will I do tomorrow because I've sent this test out. So what if this is the outcome, what else do I have to do? But I think, come home and relax. It's my biggest, advice for anyone who's a junior doctor. Just leave work at work, because it's mentally draining. It really is. And for me, my hobbies and activities, like outside of work, I'll come home, sometimes go to the gym, very, very rarely. But just, keep yourself busy when you're at home. Just, try and do all the stuff that you do enjoy. Because again, as much as I love my job, as much as I wouldn't imagine myself doing anything else, it is very, very mentally draining. It is. And you just need to find that, work-life balance for yourself, the way you do in uni. I'm sure, some people are excessive stressors, which I am myself. And you just need to learn to cope with these situations. And the more you do it and the more practice you get, it really does become second nature. And you do become very comfortable with, your job and what you should be thinking about outside of work. And don't get me wrong, I will always say do the extra bit of work at home, because I'm finding it hard to have that balance now as well. Like sometimes I come home and I'm drained, but I'm like, I do need to get that 1 hour in. So even sometimes when it comes to like portfolio work or some bits of study, there will be days where you don't have much to do in the hospital. Do it in the hospital, because once you do come home, I'm telling you, like, as much as motivation and perseverance you have, you just don't want to hear about it. You just don't want to think about it. You just want to do your own thing.
Absolutely. I think that's one thing a lot of doctors have told me. And I think one thing that helped me a lot when I started doing a lot of placements, because you're very close to the patients, and you actually end up spending more time with the consultants too, even as a junior doctor.
Yeah, I say it all the time. I'm like, other than the nurses, FY1s and SHOs are the only ones that know the patient so well. So that it is one of those things that you have a very good bond with and I think that's something I'll suggest as well. Like I might sound like a broken record, but I always put any patient I have as a family physician. I was like, if this were my sister, if this were my, father's, my mom, how would I like them to be treated? And I think it's a really good thing to have a conversation with your patients, just to get to know them, what they do, how many children do they have, what do they enjoy. Because I feel like for certain patients in the hospital, like they're going through such intensive treatment, and like, you know, for them it could be all doom and gloom, but you could be that one person that can turn their day around.
Yeah, no, absolutely. I think casual banter, for
Yeah.
lack of a better word, is in itself
Yeah,
an
because
I
I
think.
think we really forget that there's a fine line between professionalism and just humanity. Sometimes I forget as well. I'm like, oh, you know, this is what we're doing step by step, whatever. But then I'm like, this is a human being in front of you. Like, you know, what would you like to be treated? You know, someone's coming in, sticking needles in you. My favorite thing to do is, you know, if I'm doing an ABG or something very like painful for the patient, I'll explain everything to them first. But while I'm preparing everything, while I'm going in, I'll start talking to them. I'm like, oh, so, you know, how many kids do you have? Or like, you know, just kind of get their mind off exactly what you're doing at that time, just to let them know, like, you know, you're not just another patient that I'm coming in and stabbing constantly.
I think one of the doctors I worked with, he used to do, still does, he does this thing where he walks in, and if he's doing like a tricky procedure or a lumbar puncture or something like that, he'll ask them a riddle.
Yeah, and I think
Ask them a riddle.
you will come to develop your own little tips and tricks, and sometimes I'm a criminal for it. I have set lines that I use on everyone. I laugh to some of my colleagues. I'm like, if anyone was with me constantly, or the same patient saw me, they'd be like, you don't have any other jokes. Like, you don't have any other, like, my favorite one is sometimes I'll go into patients that I'm taking blood, and they're like, more blood, and I'm just like, yeah, you know, we're like vampires in here. And it's so simple and basic, but it just kind of breaks that ice. Like, it's just something very lighthearted that you can throw in there, and then just ask them, like, you know, do you find it painful? Like, you know, how many procedures? Just ask them about them. Or sometimes, other than, you know, the procedures they're having, their treatment, just be like, you know, tell me about yourself. Like, I regularly kind of just sit there with patients and be like, oh, so, you know, what do you do in your free time and stuff like that. And it is very awkward questions, and you don't really go up and say it to people, but it does open you to so much conversation. And, you know, I find it as well at work. I come across some amazing people that I learn so much off as well, like human, like, you know, life values and lessons and stuff.
Yeah. I think the other thing is like, I come across a lot of patients who don't want to talk, and who
Yeah.
really don't want to like have casual conversation. And I think like recognizing that and respecting that is just as
Oh,
important.
100%. Yeah.
But like, you know, you take your shot, and then obviously, like, you know, if the person just wants to keep quiet and wants you to do your job, then I think,
Yeah.
you know, just get on with it. But I think another thing that
Yeah.
I got advised a lot from you know, senior doctors was have a routine for when you come home.
Yeah.
So like, you know, if that's like once you get in, you take your shower, or you go to the gym, or like you water your plants. And then I think with the sleep, it was the same thing they were saying, because it's like, I think these were actually a couple of surgeons in a room who were telling me, and obviously they're very meticulous people about what they do. And they had like minute to minute bedtime routines, like things they would
Yeah.
do.
Yeah.
And it's
No,
like
you go find that.
to just sort of go and, okay, this is my time to sleep. This is my time to not think about it. This is my time to
And
relax.
even in situations, if you don't have that routine, don't beat yourself up on it, because it will take a long time to just, you know, slip into something. Because I think moving from a student to a junior doctor is a world of a difference, and getting used to it will take you a year. It might take you a couple of months, it might take you a week. Everyone's different, but just don't even beat yourself up about that, because I remember initially I used to stress out so much, like, why, like, oh, this is so stressful, whatever. And it does affect you, but at the same time, be really forgiving to yourself as well. Be like, look, this is just normal, everyone goes through, and be very open about it as well. I used to have so much conversations with my colleagues initially. They'd be like, look, it happens to everyone. And once you find, you know, that sweet spot, that routine, it's wonderful.
Okay, I have some questions over here. I think we're just getting close to the end of the webinar, so I'm just gonna like just quick fire you these. So this is actually a really interesting one. So if a just trying to picture this, if a patient is about to die, for sure, and he doesn't want his family to know, do we have to respect his decision or not? Damn.
I've never been in that situation, but yes, you have to. It's patient doctor confidentiality. You can advise them, but the more you advise them and they have their own wishes, you have to obey.
I think the other important thing is to look at capacity at that point, because
Yeah.
If a person's just about to die, like there's a very big possibility that they might not be in.
Yeah. Oh, 100. You always need to assess capacity. You really do need to assess capacity. But if someone has full capacity and they're very adamant, like, no, I don't want anyone to know right now. I mean, that's the wish. And there's other things around, like, would you like us? When would you like us to inform them? What do you want? What do you want in this situation?
Yeah, I think another one is, in what situations would you not break the bad news? So, for example, if it's harmful to the patients, and how would you sort of get a better understanding of that?
In those situations, again, you will always have to discuss with, your consultant or your reg. And there has been times where, we've found stuff on scans and stuff, and it's like, well, we cannot tell them right now. We will tell them later on, or, you do have to assess a lot of things.
Yeah, no, definitely a difficult one. How do you deal with COVID patients who are most likely to die, but the family wants to carry on the treatment? Do you put them on a ventilator regardless?
Again, we would have treatment plans in place for a lot of patients. So if the family are very adamant on, we will explain to the family, like, yes, we can do this, but we need you guys to understand that there's no good outcome for this.
Absolutely. How did you become so good at breaking bad news, even though you weren't taught it in medical school? I'm guessing this person knows you. What resources have been most helpful for you to learn?
YouTube. I was screaming out there. YouTube is my number one. YouTube taught me medicine. YouTube taught me everything I know in life right now. Definitely just watch people, like, it's one of those things, sounds a bit creepy, but just observe everyone around you. Just observe everything. And one thing I found is, in a hospital setting and you're new, please be so proactive. Like, it's very daunting to be like, can I please come and do this? I remember in my first week or two, anything that I'd be like, I have no idea what to do, I'd go to the consultant and be like, can I please come with you in this situation? Like, and everyone is so accommodating, and they want you to be like that, because they want you to learn. They want you to be a competent doctor. No one's going to be like, no, you stay out here. If it's a very serious talk and the patient doesn't want anyone else there, they'll tell you. But there's so much opportunities for you to just observe, be like, and my biggest thing is, see one, do one, teach one. I've been in so many situations where the nurses will come up and be like, can you do this? Or the reg will ask me, and I'd be like, no, I'm so sorry, I'm not comfortable in doing this. Can you come with me? Can you run through it with me? Can I see it once? And then from there on, I'll take it on. And even after the first time, if I'm not confident enough, I'll say it straight up. I'll be like, I've seen it once. This is what I do in this situation. Are you okay with me going? If not, can I see it one more time? Don't ever be afraid to say, look, I do not feel comfortable. Can you please help me?
Absolutely. I think this is something a lot of us don't actually get made aware of, especially studying in Eastern Europe, is the fact that you can say, no, I'm not comfortable doing that. And like, you really can say as a junior doctor, especially as a junior doctor, if you're it's a bit weird.
Yeah. And even till this day, like, I've been working for 4 months now. There's probably a procedure I've seen 2-3 times. Every single time that I have a patient, or even one of my colleagues have a patient, they're doing something, I'm like, do you mind if I come in with you? And no one, I've never ever been told no, like, every single time. And everyone is so accommodating. They'll sit down with you before you go in and they'll explain things to you. So I think we have that, again, not, saying people are different, but in Eastern Europe, it is quite like, we sometimes I feel like I am a burden on people because the language barrier, and they're very busy. But here, everyone has time for you, like, everyone does. And no one will shut you down for being like, oh, well, I don't think you're competent enough, you're not doing this, whatever. Like, you should express how you feel, and they'll be like, okay, because they've been in the same situation.
And they've been dealing with people who are in that situation for a long time.
Yeah. And even the FY1s here, they say to me all the time, they're like, look, we've seen it throughout med school and we're still not confident enough. Like, don't worry, it'll take time, but it'll come to you. But again, it's up to you to be that person to throw yourself. Like, I remember we had a supernumerary period, and some people took that supernumerary. Some people you just need to throw yourself, and don't be afraid. don't ever be afraid. Be like, okay, I used to set myself tasks in my first couple of weeks to be like, today I'm going to go in and I'm going to do this. So today I'm going to go in and I'm going to ask, can I see 5 patients on my own? And if you can't, you can't, but at least the goal is there, and at least you're proactive in doing stuff. Don't ever just sit in the shadows and be like, well, once this period's over, I'll jump into it. Because no, you're never going to learn that way.
Not going to survive. No,
No.
absolutely. Well, Dr. Rahman, I really just want to thank you for this amazing webinar. I think we actually got through quite a bit in terms of not just breaking bad news, but also discussing communication skills and just the idea of humanity being integrated into the job. And I think a lot of valuable lessons to take away from that. I think that's pretty much a wrap. I just want to thank everyone for being here. Also, I know I don't have my screen share up, but I just want to give a big shout out to Lectorio, our sponsors for this event. And as soon as you fill in the feedback forms, that should be in the Q&A, you'll get like a 50% discount code off, as well as your certificate. But they're a great platform. I know a lot of you have exams. It really is worth checking out. So yeah, have a look at it. I think they have a lot of free videos on YouTube.
Yeah,
so
they do.
Give that a shot first. And if you want more, it's there.
Okay, thank you so much, Mohsen, for having me. And yeah, thank you for everyone attending. I hope I covered questions. And again, I hope this was very helpful for everyone. I have a lot of people that message me and do say, we have our page, The Bitter Pill. Like, we have been very, non-responsive recently, but it's just because we've been really, really backed up. But hopefully in the future we'll be quite responsive to everyone. So don't be afraid to message us. It might take us a while, but we will get to you.
Yeah, amazing. Okay, guys, do take care. And I think we will have our next webinar in a couple of weeks. Just keep an eye on our social medias. We will definitely be posting over there a week or so before. Take care. Have a great weekend, and I will see you all soon.